Hello and welcome everyone. Today we'll be dealing with the care of frail patients in the ICU. Frailty is a state of high vulnerability for adverse health outcomes like disability, dependency, falls, need for long-term care, and ultimately mortality. It is associated with geriatric symptoms mostly, such as sarcopenia, that is muscle wasting, cognitive impairment, and dementia. Although more frequent in old age, frailty is not synonymous with old age and should be considered separately. Frailty is characterized by loss of biological reserves and heightens a patient's vulnerability to adverse health outcomes, hospitalization, long term dependency, and mortality. It is identified through comprehensive assessment of medical, cognitive, and functional problems, aiming to evaluate the patient's physiological reserve, identifying and managing long term health conditions, goals, and developing a personalized treatment plan for the patient. Frailty is syndrome resulting from cumulative decline across multiple physiological systems, posing significant challenge to the healthcare system, especially in the ICU. Understanding and measuring it is crucial to improve patient outcomes. The clinical frailty score is considered as a suitable tool for measuring frailty in urgent situations due to its ease of use and good agreement among users. So this is what is the clinical frailty scale. It ranges from 1 to 9, while 1 is very fit, 9 is terminally ill, 8 is living with very severe frailty, 7 is living with severe frailty, 6 is living with moderate frailty, and different activities have been described which describes what exactly frailty is and what is dependence is. So as the frailty increases, it just shows that the patient's reserves are very low and the chances of a good outcome are also low. Is it synonymous with comorbidities? There is a relationship. Comorbidity and frailty are interrelated, but they are distinct concepts. 70-year-old with diabetes and hypertension, one patient may be very, very fit, while the other may be very frail. So, comorbidity, though related with frailty, is not the absolute interrelated term, interconnected or changeable term. Comorbidity exacerbate the severity of the frailty and make the management much more complex. Similarly, as I described, two patients with same comorbidities may have vastly different frailty levels. Frailty is often misunderstood as synonymous with old age, though to a large extent it is okay, but it is not really a correct concept. Older individuals can be fit and robust, while younger ones can be frail due to chronic illness or lifestyle choices. Frailty, rather than age, is a more significant determinant of the patient's outcome. Now, frailty is more common in individuals aged 65 and older, but can also affect the younger population, which remains a better predictor of long term outcome rather than the age per se. In patients aged 8 and above, frailty is substantial prognostic value for ICU, hospital, and long term outcomes. The VIP2 study showed that in critically ill patients over the age of 80, frailty rather than the age was significantly associated with mortality when controlling for all other factors, which, if translated across the other age groups, probably we will show similar findings because neither age is related with frailty, rather frailty is the major thing which is associated with the mortality of the patient. Management of frail patients should focus on individualizing the care and consider the overall health status, not just the chronological age. Physiological reserves are crucial in understanding frailty in ICU patients, denoting the body's capacity to endure the stress and recover from the illness. Frail patients have significantly diminished physiological reserves, which adversely affect the clinical trajectory and outcomes because they are unable to take any bump along the road. If they are improving, that is okay, but if there is a slight deterioration in the health condition, the patients are unable to sustain because they have absolutely no reserves. Higher frailty and lower physiological reserves at baseline correlate with the reduced likelihood of a full recovery after critical illness, increasing the risk of death or recovery from significant morbidity and dependency. Frail patients often experience worse long term outcomes such as reduced quality of life, persistent functional impairment, higher mortality rates. Clinical response to organ support should be monitored as they do not necessarily predict long term outcomes. The baseline physiological reserve is indicated as frailty level and is a key prognostic factor. Admission decisions should consider the likelihood of recovery based on physiological reserve, but post admission treatment often does not differentiate based on the pre ICU frailty status. Frail patients are more likely to face limitations in life sustaining treatment due to lower survival rates. The complex relationship between frailty and the need of organ support necessitates a nuanced approach to ICU management of frail patients, carefully weighing the risks and the benefits of ICU admission and aggressive interventions. In case of uncertainty, implement a time limited trial which can help to improve predictive accuracy and minimize the exposure to potential harmful treatments. Frailty significantly impacts the ICU admission decision, necessitating the criteria that addresses the unique needs and challenges of frail patient. Integrating frailty assessment into the admission process enhances the evaluation of a patient's suitability for ICU care, aiding in more informed decision making about the potential benefits and risks. Say, for example, my patient is already very frail, almost terminally ill. In that case, admitting this patient to the ICU is unlikely to change the outcomes. So, family discussions, understanding the patient's will and all is going to be more important than going for aggressive management of these patients. And moreover, we cannot really change the condition to better. If the patient is already very frail, our treatment is unlikely to make the patient better than what the patient was before. In urgent situation where ICU admission decisions are needed quickly, comprehensive geriatric assessment are impractical due to the time constraints and patients' cooperation requirements. Alternative tools, like we have discussed, that is clinical frailty scale, are commonly used to assess the frailty swiftly. Admission of frail patient should consider clinical indications, shared and informed goals of care, quality of life, and potential long-term outcomes. Incorporating frailty assessment into the ICU admission can lead to better resource utilization, improved patient outcomes, and more ethical sound decision making. Frailty impacts ICU outcomes differently between medical and surgical patients, with frail surgical patients facing higher risks of post-operative complications and prolonged recovery periods. Conducting a frailty assessment prior to the surgery is important and can benefit for elective post-op care, enhancing recovery prospects and reducing the risk of complications. Multidimensional frailty scores are more effective than the traditional ASA scores in predicting post-operative outcomes in these patients. The COVID 19 pandemic has underscored the vulnerability of frail patients to severe outcomes, reconfirming the relevance of frailty assessment in managing new and emerging diseases as well. Effective communication with the patient and the family about the frailty is crucial, involving a clear explanation of what frailty is and its implication to the treatment and outcome. The reasoning behind specific management decisions can be better explained to the relatives. Engaging in compassionate, respectful dialogue is essential, ensuring that the conversation aligns with the patient's values and preferences. Informed consent and shared decision making are vital in the care of frail patients, particularly when the potential interventions carry significant risks and benefits. Healthcare providers should aim to establish a trusting relationship with patients and their families, promoting a mutual understanding of frailty and how it influences treatment choices. So, to summarize, before the patient gets admitted to the ICU, we look at the various factors. Frailty is the most important out of them because this is the indicator of physiological reserve of the patient. Apart from that, you take into account the age, the comorbidity, whether the patient is going for an elective surgery or patient has an acute medical illness. Based on this, the admission decision and a multi-dimensional assessment of the frail patient is to be done. Now, once the patient is in the ICU, we need to make decisions. So, decision making is very, very crucial, and for that, we need the frailty scores of the patient. If the patient is very frail, then a time limited trial of treatment can be given, where we give a very limited period of time intensive treatment, and if we find no improvement, we do not escalate, and we counsel the relatives regarding the worst outcomes or the fact that the patient is unlikely to survive. And obviously, initiate the end of life decisions. Now, whether the patient is developing more and more organ failure, how aggressively I should treat them, whether I should be going for intubations or dialysis, and all that should be discussed. The involvement of a geriatrician should be done. And while we are doing all this, the patient's will and the shared decision making with the relative is a must. In all these factors, the frailty and its score becomes very, very important, because based on that, we are doing a lot of decision making, and also discussion with the family is based on that only. Apart from that, the frailty affects the trajectory in the ICU, because, as we have already discussed, the patient may not be able to sustain the lows. They may, as long as they're improving, it is fine, but once you hit a complication, they may not recover again. It also emphasizes the impact of post ICU care they need to be given in terms of physiotherapy and nutrition to at least bring them back to the level of activity they were at home. It also will affect the short term outcomes, that is, the mortality rates, and finally, the long term outcomes as well, which is the quality of life. So, managing a frail patient is very important. So, to know the baseline status is the most important first thing. Next is the physiological reserves. Finally, how we are going to take our decisions based on these frailty scores. Thank you for your patience.